Hello everyone, I'm Dr. Khanna, one of the Neurophysiology fellows, and she is Dr. Aish, another fellow. And here, welcome to this EMG course that we are starting. And this is a short video that we are gonna do to introduce what EMG is, just basics of EMG and how to interact with the patient. And then during the course we may do a few more videos to try to give you as much information about EMG as we can in these short videos. Okay, so when you get a patient who is coming here for EMG, he or she is very anxious and don't know what to expect in this test, as the referring physician are not that good with EMGs, and they don't know how to calm the patient and what to tell and what not to tell the patient. So this is very important first to calm the patient down. And I'm gonna just show briefly if Doha is a patient coming in for an EMG and maybe has a lot of questions like what this test gonna be like, and we are gonna just show you how to interact with the patient and how to tell them what this test gonna be like. So, good morning, Miss Aish. How are you doing?
I'm good. How are you, doctor?
I'm good. Hope you had a good night's sleep last night.
Well, I was a little stressed out because of the test
Because
I'm
of this
having.
test,
Yeah.
I can understand. So I'm gonna tell you briefly what to expect in this test. So this test has two parts. In the first part of the test, we check your nerves, and in the second part of the test, we check your muscle. And your doctor sent you for the particular condition. This test is very important for your doctor to make a final diagnosis. So what we will do is in the first part where we check your nerve, we give small electric shock to different parts of the nerves and see how those nerves are conducting basically. And in the second part of the test, we put small acupuncture sized needle in different muscles.
Okay.
I know that this sounds
Wow. Okay.
scary,
Yeah.
but I can assure you that most patients do tolerate this test pretty well.
So it's
And
pretty
this
painful, huh?
this needle is pretty small. It's acupuncture size. I would not say painful or not, but yes, this test, as it sounds, this is an uncomfortable test.
Okay.
But as I said, most patients do tolerate it very well.
Okay.
Now, if you feel like that this is something you are not able to tolerate or it's too painful, you can always tell us. You are the boss.
Okay.
And you can let us know if you want a break, if you want to stop the test. I can assure you that we will try our best to make you more comfortable and start from small shocks, slowly go up on the intensity.
Okay.
But you should be aware that we need to get the best responses of your nerves so that we don't misdiagnose you. So we
Okay.
will need to go higher intensities.
Okay.
Okay. Do you have any questions?
No, I think you explained everything pretty much. Thank you.
One question before we start the test. Are you on any blood thinners?
No, I'm not.
Okay. We wanted to ask you to make sure that we don't do any harm to you.
Okay.
Okay.
Okay. So.
Okay. So this is a small brief that you can tell the patient to calm them and try to answer all their concerns. And for any EMG nerve conduction study, and Dr. Aish can jump in anytime to give more information. But for any patient, the first thing is not the test. The first thing is history and good clinical exam. because without that you may be doing hundreds of nerves and hundreds of muscles. You may not lead to anywhere. You should have something in your mind. Why are you doing the test? What is that you are looking for, and which nerves you should do, and which muscles you should do, and why what will you do if you see a particular abnormality in that nerve or muscle. So to get that plan of doing what you want to do with this machine, first you need to have a good history and good examination. That cannot be less told you less often. So
Okay.
do you want to add anything, Dr. Aish?
No, I think you should have like a list of differentials before you proceed to the test, just like you said, so you can be focused in terms of like which nerves and which muscles you want to target. And of course, after that, like you did, you explained to me the procedure, the risks and benefits and everything, which was a great approach to.
Mm-hmm.
Okay, I think that's
Yeah.
That's it.
So now during during this course we will learn about multiple things. We will learn what this machine looks like and different things during the course. But what we are going to show you now, what we are looking for. So I'm gonna show you a sample report and go over the components of the EMG and nerve conduction study, so that when you come for the course you are at least oriented to what we are talking about. Okay, so let's turn to the report now and we'll talk more about it. Okay, so as I was saying about the report, so this is how sample report looks like at our program. So first of all, it will have all the demographics of the patient. I have just hid those demographics of this patient for HIPAA reasons. And small history and exam is always needed. This cannot be less stressed. So if you can take a brief history and exam before you make a plan of the EMG, you have to do that. Okay, and then we will go and talk about what we are looking for. So first, these are the sensory nerve conduction. We have abbreviated that as SNC. So as this sample patient was done for neuropathy or myopathy, we have done one arm and one leg. In this report, we are looking at sensory nerve conduction, and to cover some basics, the sensory nerve conduction action potential are also briefed as SNAPs, SNAPs, sensory nerve action potential. So what you do for that, you have to when you put the recording electrodes and shock the nerve, you record the potential. You look at when the stimulus is given and when the action potential starts. That time period is called onset latency, which is marked here as well. And then the amplitude goes up towards the y-axis, and when it peaks, that's the point from the stimulus and to the peak is called peak latency along the x-axis. And the y-axis to the peak is the voltage by which it goes up, and that's the amplitude of the action potential. Now for the sensory nerve potential, we do check the distance from the stimulus to the recording electrode and divide that distance with the onset latency to find out the conduction velocity. Now this is different for motor nerves, and we'll talk about that when we talk about the motor nerve action potentials, which is CMAPs, or compound motor action potentials. Now, thing to note about this is that we have mentioned about temperature for every action potential, and temperature is very important, and it can affect your latencies, conduction velocity, and even amplitudes in different ways, and we will talk more about it in interactive sessions. Now, how do you know what is the normal values for these? So for each value we have innovative data, which comes from all the average, whatever studies have been done in the past, and average have been taken out from the normal patients, and these normative values are different for different patients in different age groups, so it has been divided into different groups. I'm going to show you the chart which has the normative value, so that you can have idea how it looks like. So this is the normative value chart, which has been divided into age groups 10 to 29, 30 to 49, 50 to 59, and 60 and up, and each nerve has a different normal value for latency, amplitude, and conduction velocity, and also each nerve at different, whether it is sensory or motor, or if it is motor, then it also matters if which muscles we are recording at these values will have different normative values. So let's go back to the report. Sorry. Okay. So this is a brief about sensory nerve conductions, and in this report they have tested for surals and in upper extremity, medial ulnar, and radial nerves, which is the usual protocol for any extremity. Okay, let's go down and see what else we have. So now we come to motor nerve conductions. So for motor nerves, as I was telling you earlier, we have CMAPs, which is compound motor action potentials. Now for CMAPs, the similar things with sensory nerve action potential is when you stimulate to where you are recording the G1, you have the time period is the distal latency. Now notice the difference in the snaps. We said onset latency, but here we are using the term distal latency instead of onset latency, because in snaps what we measure is peak latency and compare peak latency from one nerve to other, whereas and not the onset latency. And we can talk more about it in the interactive session why we do that, but in motor nerves we only look at the distal latency, which is the time from stimulus to the onset, not to the peak. And you remember when we talk about sensory nerve action potential, calculating velocity was easy because we can just divide the distance by the onset latency, not the peak latency, onset latency. But in motor nerves we cannot do that, because when we are recording from a muscle and stimulating the nerve, in that path you interact with the nerve, then neuromuscular junction, and the muscle itself. So there is the time that is also coming from conduction in the neuromuscular junction and the muscle. So we don't want to falsely elevate our time component of the of checking the velocity and reduce the velocities. So that's why in the motor nerves we usually stimulate at distal site and the proximal site, and depending on the nerve we may need to do at more than two sites. Now when we check at the proximal site, we subtract the latency of the proximal side with the distal side, and uh, calculate the conduction velocity from there. So we measure the distance between the distal and proximal, and divide it with the um, with the time it takes from the distal to proximal side by subtracting the latencies. So that's a brief about it, and we can clarify more questions when we meet in the interactive session. Now, other thing to note about in the motor nerve action potential, of course, the normative values of latency, amplitude. Amplitude is similar to what I explained in the sensory nerve, and the velocities is to make sure when we go from distal to proximal side, the amplitude does not drop too much. If the amplitude drops by more than 20%, that is indicative of what we call as conduction block, and that has lot of significance in interpreting the EMG, and we can talk about it more in the interactive session or further videos when we make it. But that's one important thing to note when you read through the EMGs. So similarly, in this sample report, we did 2 motor nerves in the left leg and 2 in the left arm. Make sure when we are comparing latency from the normative value, we are only comparing the distal latencies and not the proximal latencies. Then we look at F waves. I'm not gonna go in detail of the F waves in this video. We can talk in further sessions and further videos in detail about late responses. And briefly about EMGs. So for the EMGs, I'm just gonna say what to look for in this table. So we did this needle EMG in different muscles in upper and lower extremities. So when you put the needle in the muscle, you look at 2 different things. Number one, you look at what you are seeing in the muscle at rest. So you are just inserting the needle, you will see the insertional activity, which is designated as IA here. You see how the insertional activity looks like. The normal is usually less than 300 millisecond. If it is less than 300 millisecond, it is normal. Then you keep your needle still for at rest for few seconds and see if you notice any spontaneous activity. Usually spontaneous activity is abnormal except for few spontaneous activities. The normal spontaneous activities are your end plate action potential and end plate spikes. End plate spikes and end plate waves. Otherwise, usually all the spontaneous activities are abnormal. So you look at those abnormal spontaneous activities can be fibrillation, designated as fib here, positive sharp waves, designated as PSW, fasciculations, or there can be lot others we can talk about in further sessions like CRDs and myochymia, etc., etc. And then we look at the motor action potential, which is when we ask the patient to activate the muscle in the according to the what muscle we are checking. So we look at the morphology of the motor unit action potential in different ways. Like we see how many phases it has. If it has more than 4 phases, it is polyphasic. If we look at what is the amplitude of the wave. If it is more than or equal to 4 millivolts, then it is a big amplitude, and we have to note that. Then some cases like myopathies, you can have small amplitudes also. then you look at the duration, how long the wave was. If it was more than 15 millisecond, then you are worried about long motor action potentials. And we look at the firing rate. If one motor unit is firing multiple times, and it's at increased rate, that would be seen in neuropathic action potentials. Now we come to the recruitment, and we can talk more about the recruitment ratios and how we calculate that in the interactive session. And we look at that. Of note, in neuropathic lesion, you will see decreased recruitment, which really means that because the nerve is injured, it has to the muscle cannot fire. Muscle cannot recruit motor units, so it has to fire more. It has to fire at an increased rate. And we can also note how much effort is the patient giving. If patient has an upper motor neuron lesion, or if the patient has too much pain, he may not be giving enough effort, or he may not be activating the muscle enough. So it's worth noting that. And that can affect the number of motor units you are seeing. And this is a brief normal limits that's noted in the report, but it is the other chart that I showed you earlier, this one, which has the normative values, this one. Okay, so any questions? We will talk more about it in the interactive session. But after all the details, we usually summarize our finding and write an interpretation depending on what case we have, and we will do few cases so that you can be more versed how to read an EMG report, and you can read your reports yourself, and you don't have to just read the final impression. Dr. Aish, do you have to add anything to it?
No, I think you covered everything, Dr. Khanna. That was a good explanation of the reports.
And thank you very much. See you in the first session on Monday.